Welcome to our video on common adult orthopedic injuries of the upper extremities. Let's get started. Here's our overview slide. Let's begin by discussing shoulder dislocation. The shoulder is the most commonly dislocated joint in the body due to relatively poor articulation of the humeral head with the glenoid fossa. More specifically, an anterior shoulder dislocation is the most common type of shoulder dislocation. Its mechanism of injury is either a direct blow to an externally rotated abducted arm or a fall on an outstretched arm. Physical exam will reveal an abducted and externally rotated upper extremity along with flattening of the anterior shoulder or the deltoid prominence. It's important to know that anterior shoulder dislocations are associated with injury of the axillary artery and the axillary nerve. As a general reminder, the axillary nerve innervates the deltoid muscle, the teres minor, and an area of the skin overlying the inferior portion of the deltoid. As such, injury to this nerve can result in weakness of shoulder abduction and paresthesias of the lateral shoulder. Let's compare an X-ray of a healthy shoulder joint on the left with an X-ray of an anteriorly dislocated shoulder joint on the right. Looking at the left image, here is the head of the humerus, articulating well with the glenoid cavity of the scapula. Looking at the image on the right, the head of the humerus is significantly displaced and no longer articulates with the glenoid cavity of the scapula. Anterior shoulder dislocations are characterized by displacement of the humeral head anterior, inferior, and medial to its normal position with respect to the glenoid cavity. A variant of this X-ray may show up on exams, and examiners may expect students to distinguish it from a posterior shoulder dislocation based on imaging alone. So let's discuss that next. Posterior shoulder dislocations are uncommon and are typically presented on exams in the context of a seizure or electrocution. This is because either of these two events can lead to uncontrolled violent muscle contractions that can dislocate the shoulder posteriorly. Physical exam will reveal an adducted and internally rotated upper extremity, along with flattening of the anterior shoulder or the deltoid prominence. Note the key difference on physical examination of the posterior shoulder dislocation versus the anterior shoulder dislocation. Recall that anterior shoulder dislocation presented as an abducted and externally rotated upper extremity, which is in direct contrast to the adducted and internally rotated upper extremity seen in cases of posterior shoulder dislocation. So again, let's compare an X-ray of a healthy shoulder joint on the left with an X-ray of a posteriorly dislocated shoulder joint on the right. Looking at the left image, again, note the considerable overlap between the head of the humerus and the glenoid cavity of the scapula. Looking at the right image, note how little overlap exists between the head of the humerus and the glenoid cavity of the scapula. Posterior shoulder dislocations are characterized by posterior displacement of the humeral head and considerable loss of overlap between the humeral head and the glenoid cavity of the scapula. X-rays of posterior shoulder dislocations often depict the so-called light bulb sign, wherein the head and neck of the humerus appear to look like a light bulb. Lastly, note that with posterior shoulder dislocations, the head of the humerus remains lateral to the glenoid fossa. This is in direct contrast to an X-ray appearance of an anterior shoulder dislocation, wherein the head of the humerus shifts medially and inferiorly to the glenoid cavity of the scapula. Knowing these key distinctions will help you confidently distinguish an anterior and posterior shoulder dislocation based on imaging alone. The diagnosis of a suspected shoulder dislocation is always confirmed with a two-view X-ray of the affected shoulder, which includes the antero-posterior view and the lateral view. The treatment begins with closed reduction of the dislocated shoulder, followed by immobilization of the joint with a collar and cuff or a sling and swath for 1 to 3 weeks. Physical therapy is often employed to hasten recovery and help restore functionality. Surgery is typically reserved for patients who experience a high recurrence rate, which unfortunately is the most common complication of shoulder dislocations, particularly in young patients. This higher recurrence rate is thought to be due to a higher type 3 collagen content in the shoulder capsule and ligaments of patients under the age of 20, compared to the tougher type 1 collagen, which is more abundant in patients over 40. Type 3 collagen is more supple and likely results in greater joint laxity and thus a greater propensity for recurrent dislocations. All right, let's try a question. A 19-year-old female with a history of epilepsy is brought into the emergency department following a tonic-clonic seizure. Physical examination reveals an adducted and internally rotated right arm with flattening of the deltoid prominence. What is the most likely diagnosis? All right, a recent seizure episode, along with physical examination findings of an adducted and internally rotated upper extremity, strongly suggest a posterior shoulder dislocation as the most likely diagnosis. As a reminder, posterior shoulder dislocations are rare and typically follow either a seizure or an electrocution episode. Patients with posterior shoulder dislocations typically hold the affected arm in an adducted and internally rotated position, which is in contrast to patients with an anterior shoulder dislocation who will typically hold the affected arm in an abducted and externally rotated position. All right, let's move on to rotator cuff tendinopathy and tears. The rotator cuff is comprised of 4 muscles: the supraspinatus, infraspinatus, teres minor, and subscapularis. They're often remembered using the SITS mnemonic, which spells out the first letters of the rotator cuff muscles. Note that the letter T is the only letter that isn't capitalized to remind you that it's the teres minor, not the teres major. Among the 4 rotator cuff muscles, the supraspinatus is the most commonly injured muscle. Both rotator cuff tendinopathy and rotator cuff tears fall under the umbrella of rotator cuff injury, so let's discuss them in more detail. Rotator cuff tendinopathy is caused by overuse, impingement, or inflammation of the rotator cuff muscle tendons. Physical exam will reveal pain in the joint, but no weakness. The presence of weakness on examination of the shoulder would indicate a rotator cuff tear rather than tendinopathy. Hence, assessing for weakness on physical exam is one of the best ways to distinguish tendinopathy from tears. Most clinicians will also assess for tendon impingement by performing the special impingement tests of the shoulder, namely the Hawkins-Kennedy test and the Neer test, which we'll discuss in greater detail in the next few slides. Otherwise, the diagnosis of rotator cuff tendinopathy can be confirmed with an ultrasound of the shoulder, and the treatment is conservative with rest, ice, pain meds, and physical therapy. Here's what the Hawkins-Kennedy test of the shoulder looks like. To perform this test, the clinician first brings the patient's glenohumeral and elbow joints into 90-degree flexion. The clinician then stabilizes the shoulder with one hand and internally rotates the shoulder using the other hand. The Hawkins-Kennedy test is deemed positive if the patient reports pain with this maneuver. The test has a sensitivity of 79% and a specificity of 59% in the diagnosis of shoulder impingement. Here's what the Neer test of the shoulder looks like. To perform this test, the clinician passively flexes the glenohumeral joint with one hand while stabilizing the shoulder with the other hand to prevent shoulder shrugging. The test is deemed positive if the patient reports pain with this maneuver, which is why this special test is sometimes referred to as the passive painful arc maneuver. Similar to the Hawkins-Kennedy test, this test has a sensitivity of 79% and a specificity of 53% in the diagnosis of shoulder impingement. Now let's move on to rotator cuff tears. Rotator cuff tears are more commonly seen in patients over 40. The mechanism of injury is either trauma to the shoulder or a fall on an outstretched arm. Physical exam will reveal pain and weakness and may reveal a positive drop arm test or a positive empty can test, which we'll discuss in greater detail on the next few slides. Once again, the presence of weakness on exam of rotator cuff tears is in direct contrast to rotator cuff tendinopathy, which presents with pain but no weakness. The diagnosis is confirmed with an MRI of the shoulder joint, and the treatment for acute tears is surgical repair of the torn tissue. For chronic tears, on the other hand, conservative management is attempted first, followed by surgery in refractory cases. Here's what the drop arm test of the shoulder looks like. To perform this test, the clinician first brings the patient's arm into full abduction and external rotation and asks the patient to gradually lower the arm upon release. The test is considered positive if the patient's arm drops instead of being lowered gradually and smoothly with or without associated pain. The drop arm test has a low sensitivity and a high specificity in the diagnosis of rotator cuff tears. Here's what the empty can test of the shoulder looks like. This test is also commonly referred to as the Job test. To perform this test, the clinician first asks the patient to elevate the arms to the level of the shoulder, extend the elbows, and rotate the forearm to have the thumbs pointing down and palms facing outward as shown on the slide. The clinician then applies gradual downward force on the arms and asks the patient to resist the force. The empty can test is considered positive if the patient reports pain with this maneuver or cannot resist the downward force due to weakness. The MT-CAN test has a high sensitivity and moderate specificity in the diagnosis of rotator cuff tears. Here's an MRI of a shoulder depicting a complete supraspinatus tear. Note the significant gap between the two halves of the supraspinatus muscle. As a reminder, the supraspinatus muscle is the most commonly injured muscle within the rotator cuff. Next, let's move on to adhesive capsulitis. Adhesive capsulitis is a disorder characterized by significant stiffness and limited range of motion of the affected shoulder, which is why this disorder is also known as the frozen shoulder. It's associated with type 2 diabetes, thyroid disease, and a history of shoulder injuries. Physical exam reveals stiffness, dull pain, decreased passive and active range of motion, but no weakness. The diagnosis may involve ultrasound, X-ray, and/or MRI of the affected shoulder to rule out rotator cuff injury and other causes of shoulder pain. The disorder is largely self-limited, so it's treated conservatively with pain medications and physical therapy. All right, let's try another question. An 18-year-old female presents to clinic with a chief complaint of left shoulder pain. She is a pitcher on her school's softball team. Physical examination reveals full active and passive range of motion and strength in both shoulders. However, when the clinician brings the patient's left glenohumeral joint into full flexion, she reports pain. What is the most likely diagnosis? All right, the patient in question is a pitcher on a softball team, which puts her at risk of overuse injury to her shoulder. When the clinician performs the NEAR test by bringing the patient's left shoulder into full flexion, she reports pain. Putting these clues together, the most likely diagnosis is rotator cuff tendinopathy secondary to shoulder overuse. Adhesive capsulitis and rotator cuff tear are unlikely for two reasons. First, the patient in question is young, and both adhesive capsulitis and rotator cuff tears are more common in patients over the age of 40. Second, on physical examination, she had full active and passive range of motion, which makes adhesive capsulitis unlikely, and full strength, which makes a rotator cuff tear unlikely as well. Let's move on to high-yield fractures of the upper extremities, focusing primarily on the most testable features of each fracture. The first fracture we'll discuss is a fracture of the humerus shaft. Humerus shaft fractures are generally a result of trauma, such as a direct blow to the upper extremity, a fall, or a motor vehicle accident, and they're associated with radial nerve injury. This is because the radial nerve courses through the spiral groove on the posterior surface of the humerus. Injury to this nerve may manifest itself as paresthesias over the dorsum of the hand, wrist drop, and loss of metacarpophalangeal joint extension. Notably, extension of the interphalangeal joints will still be intact because the muscles responsible for extension of these joints are innervated by the ulnar nerve and the median nerve, not the radial nerve. The diagnosis of humeral shaft fractures is confirmed with X-ray of the affected upper extremity. In most cases, the treatment is non-surgical, with closed reduction and arm immobilization. Surgical treatment with open reduction and internal exploration is indicated in cases of open fractures, significantly displaced fractures, or if there's evidence of neurovascular compromise. Here's an image depicting a significantly displaced humerus shaft fracture. The radial nerve courses through the radial groove on the posterior surface of the humerus before wrapping around the humerus and descending further towards the forearm. Its course puts it at high risk for injury in the setting of humeral shaft fractures. Moving on to the Colles fracture. Colles fracture is a fracture of the distal radius with dorsal angulation and impaction. The term dorsal angulation in this particular case means that the tip of the fractured radius is pointing towards the dorsal side of the wrist, which means away from the palm. A fracture with volar angulation, on the other hand, would be pointing towards the palmar side of the wrist. The term impaction means the broken ends of the bone were jammed together by the force of the injury. The classic mechanism of injury is a fall on an outstretched hand. Physical examination will reveal a dinner fork deformity of the wrist, which refers to the dinner fork-like appearance of the wrist when viewed from the side. We'll show an image of this on the next slide. Additionally, patients may present with median nerve palsy, as dorsal angulation of the distal radius may injure or compress the median nerve as it courses through the carpal tunnel. Hence, patients may exhibit symptoms of carpal tunnel syndrome, such as impaired thumb, abduction, and paresthesias in digits 1 through 3. As with most fractures, the diagnosis is confirmed with x-rays. In the vast majority of cases, the treatment is non-surgical with closed reduction and cast immobilization. Generally speaking, surgery is reserved only for unstable fractures, which are fractures that have a high tendency to displace after closed reduction. Examples of such fractures would be those that lead to significant dorsal angulation or wrist instability. Here's what the dinner fork deformity may look like in a real patient who may sustain a Colles fracture. The dorsal angulation of the wrist somewhat resembles a dinner fork. Here's what the Colles fracture looks like on a series of x-rays of the wrist. Note how the distal radius is angulated towards the carpal tunnel, where it can compress the median nerve as it courses through the carpal tunnel and lead to median nerve palsy. Next, let's discuss the scaphoid fracture. The scaphoid bone is the most commonly fractured carpal bone. The most common mechanism of injury is a fall on an outstretched hand. Physical exam typically reveals pain in the anatomical snuff box, which is a triangular depression in the dorsoradial aspect of the hand, best seen with the thumb extended and abducted. Patients can also present with pain when performing pinching maneuvers. The diagnosis begins with x-ray of the wrist and hand, although it's important to note that x-rays of scaphoid fractures are often falsely negative. A negative x-ray prompts either more advanced imaging, such as a CT scan or MRI, to definitively rule out a fracture or simply empiric treatment. The most common treatment approach is a thumb spica splint, followed by repeat imaging in 7 to 10 days to ensure appropriate healing of the fracture. Surgery with open reduction and internal fixation is typically reserved for displaced fractures or if there is high risk for non-union, which is one of the most common complications of scaphoid fracture. Because of the poor blood supply to the scaphoid bone, scaphoid fractures can also be complicated by avascular necrosis. Here's an image of a left hand with the thumb extended and abducted, and here's that triangular depression on the dorsal and radial side of the hand that's referred to as the anatomical snuff box. It's an area that will most likely be painful in a patient with a scaphoid bone fracture. Here's an x-ray depicting the scaphoid fracture, which is marked with an arrow. Once again, x-rays can be negative on initial presentation of scaphoid fractures and thus cannot be used to definitively rule it out. Now let's move on to boxer's fracture, which is a fracture of the neck of the fifth metacarpal bone. The most common mechanism of injury is direct trauma to a clenched fist, such as when punching a wall or an opponent in a fistfight. Interestingly, though this fracture is common among inexperienced boxers, it's uncommon among experienced ones, making its name somewhat of a misnomer. Physical exam reveals pain and swelling at the fracture site. The diagnosis is confirmed with x-rays of the affected hand. The treatment is typically non-surgical with closed reduction, an ulnar gutter splint, as well as the usual conservative measures, such as rest, ice, and pain medications. Surgery is reserved for complex fractures, such as open fractures or severely angulated fractures. Here's an x-ray of a left hand demonstrating a fracture in the neck of the fifth metacarpal bone. Next, we'll discuss Monteggia fracture. This is a diaphyseal fracture of the proximal third of the ulnar shaft with dislocation of the radial head. The mechanism of injury is a fall on a pronated outstretched arm. Physical exam reveals pain and swelling at the elbow joint, and the diagnosis is confirmed with an x-ray of the elbow joint. The treatment is often surgical, with open reduction and internal fixation of the ulnar shaft fracture and open reduction of the radial head. Here's an x-ray depicting the Monteggia fracture. You can see the significant fracture of the proximal third of the ulnar shaft along with the dislocated head of the radius. Next up, Galeazzi fracture is a fracture of the distal third of the radius shaft with dislocation of the distal radio-ulnar joint. The mechanism of injury is either direct wrist trauma or a fall onto an outstretched hand with the forearm in pronation. Physical exam reveals pain over the fracture site along with local swelling and deformity. The diagnosis is confirmed with x-rays of the affected upper extremity, and the treatment is almost always surgical, with open reduction and internal fixation of the radius and stabilization of the distal radio-ulnar joint. Here's an x-ray depicting the Galeazzi fracture. You can appreciate the fracture of the radius here on the antero-posterior view, as well as the significant dislocation of the radio-ulnar joint here on the lateral view of the upper extremity. All right, let's try another question. A 24-year-old male is brought to the trauma bay by EMS following a high-speed motor vehicle collision. The patient's right upper extremity is visibly shortened when compared to the left upper extremity, and a portable X-ray reveals a right humerus shaft fracture. What is the next best step in management of the fracture? All right, visible shortening of an extremity indicates a significantly displaced fracture, which warrants prompt operative repair with open reduction and internal exploration. So, in short, the next best step in management is surgery. Let's conclude this lecture with a discussion of decorvane tenosynovitis and Dupuytren's contracture. Decorvane tenosynovitis is characterized by pain at the radial side of the wrist, and it's caused by overuse of the abductor pollicis longus and extensor pollicis brevis. Generally speaking, women are affected by this condition more often than men. In fact, the classic patient is a first-time mom who frequently lifts up her infant by the armpits, thereby exerting frequent and significant stress on the tendons of the aforementioned muscles. The diagnosis is clinical and is supported with a positive Finkelstein test, which we'll demonstrate on the next slide. The treatment is conservative, with a thumb spica splint and pain medications as necessary. Here's a series of images demonstrating the Finkelstein test. The patient is first asked to flex the thumb and place it in the middle of the palm. The patient is then asked to close the fist as seen on the bottom left image and ulnar deviate the wrist or tilt the wrist in the direction of the pinky, as shown on the bottom right image. The presence of significant pain on ulnar deviation of the wrist with the thumb flexed inside a closed fist is considered a positive Finkelstein test and is strongly suggestive of decorvane tenosynovitis. Dupuytren's contracture is an autosomal dominant disorder characterized by painless fascial nodules and contractures on the palmar side of the hand. The disorder stems from abnormal connective tissue formation in the palmar fascia as a result of myofibroblast overactivation. The classic presentation on exams is contracture of the ring finger in an older male. Generally speaking, this disorder is seen about twice as much in men as it is in women, and it typically presents in patients over the age of 50. The diagnosis is clinical, and the treatment may involve physical therapy, corticosteroid injections, clostridial collagenase injections, and fasciotomy if there's severe functional disability. Steroid injections work by decreasing inflammation and pain in the area, and can also lead to regression of the contractures. Clostridial collagenase injections, on the other hand, work by dissolving the excessive connective tissue, thereby facilitating the resolution of the contracture. Here's what a Dupuytren's contracture may look like in real life. Here's a table summarizing the most salient and high-yield concepts discussed in this lecture. You may find it useful to return to this table when reviewing the common adult orthopedic injuries of the upper extremities before your exams. Let's conclude this lecture with a multiple-choice question. A 44-year-old man presents to his primary care provider with the chief complaint of worsening left shoulder pain. He says working in construction has been more challenging ever since the pain and discomfort started 3 months ago. Past medical history is notable for type 2 diabetes and hypothyroidism, for which he takes metformin and levothyroxine, respectively. There is no record of prior shoulder injuries or surgeries. Vital signs are within normal limits. Examination of the left shoulder reveals decreased passive and active range of motion, but no weakness. Passive flexion of the left glenohumeral joint does not elicit pain. There are no sensory deficits of the left upper extremity. The remainder of the musculoskeletal examination is normal. Which of the following is the most likely diagnosis? A. Rotator cuff tendinopathy. B. Rotator cuff tear. C. Adhesive capsulitis. Or D. Glenohumeral osteoarthritis. All right, the correct answer is C. Adhesive capsulitis. There are several clues in the vignette that strongly suggest this diagnosis. First, the patient in question endorses insidious shoulder pain over the course of 3 months. Second, he has a history of type 2 diabetes and hypothyroidism, which are considered to be risk factors for adhesive capsulitis. Third, his physical examination is notable for decreased passive and active range of motion, which is strongly suggestive of adhesive capsulitis. Option A, rotator cuff tendinopathy, is less likely in this patient because passive flexion of his left glenohumeral joint, which is referring to the Neer test, did not elicit any pain. Option B, rotator cuff tear, is also unlikely in this patient because he had no weakness on examination of his left shoulder, and rotator cuff tears almost always present with weakness. Lastly, option D is incorrect because shoulder arthritis is typically caused by repeated trauma to the joint. Since this patient does not have a record of prior shoulder injuries or surgeries, glenohumeral osteoarthritis is less likely than adhesive capsulitis. So again, the correct answer is C, adhesive capsulitis. And that concludes this section.